We're going to get real about PCOS and PCOD.
Polycystic ovarian syndrome is an interplay, a vicious circle of cause and effect.
Google is telling me I'm not going to have a baby.
They are also exposed to having a higher risk of cancer.
Obesity, diabetes, blood pressure. You cannot lose weight on the treadmill. You're going to only manage the fat loss in the kitchen. Most people in India are protein deficient.
When do the symptoms first start appearing?
That they should never try to regularize the cycles by drugs.
Welcome to another episode of JIVI Explains. We're going to have a science-backed, evidence-based discussion on PCOS PCOD. We have with us two leading experts in the field, Dr. Roshni Sanghani, who is an American board-certified endocrinologist with an MD in internal medicine, diabetes, hormones, and metabolism. She's also the founder of Resan Health, and she's the author of her book titled Turn Around Diabetes. Welcome, Dr. Roshni.
Thanks for having me, Pooja.
We also have with us Dr. Uddhav Raj, who is a gynecological, laparoscopic, and robotic oncosurgeon. He's a fertility enhancing specialist who conducts pelvic floor repair surgery. He has over 2 decades of experience in this field. Welcome, Dr. Uddhav Raj.
Thank you very much for this invitation.
So today we're going to get real about PCOS and PCOD. In the first segment, we are going to discuss and understand what is PCOS and PCOD. So my first question is for you, Dr. Uddhav Raj. What is the difference between PCOS and PCOD? Because oftentimes they are used interchangeably.
So I think commonly now we face, because for a simplest problem, it is very easy to undergo an ultrasound. And when women or girls, typically for even a simple complaint like abdominal pain, undergo an ultrasound, there will be a coincidental finding of PCOD. So whenever a radiologist sees multiple follicles in the ovary, follicles means they are the actual holders of the eggs, female eggs. And when they see more than one as a chain of pearls, they call it polycystic ovarian disease. So polycystic ovarian disease is just one component. When it is actually compounded by other metabolic signs like weight gain, growth of hair on the face, irregular menstruation, and many other issues like even loss of sleep, stress, these things will form in a complete, then this in terms of medical also have insulin resistance and also androgen, hyperandrogenism, which leads to other symptoms. So these can be ranging, it forms a complete syndromic representation, then it is called as PCOS.
I think very few people really understand the difference. So thanks for clarifying that. Ma'am, has the occurrence of PCOS or PCOD increased in the past decade, and why do you think so?
The answer is yes. Maybe partly because, as Doc said, more women or girls are coming in for ultrasound, so we might be picking up more cases. Maybe my grandmother didn't get access to an ultrasound when she was a young girl. So it might be that we're picking up more cases. They were always there. Or there is more incidence that this disease is actually occurring more often. And I do think that that's true, that it is occurring more often because it moves in parallel with this overall global epidemic that we're facing, which is this insulin resistance metabolic syndrome epidemic, the worldwide diabetes and obesity epidemics, which are on the rise. And PCOS moves in parallel with that because of insulin resistance being the key.
What are the causes of PCOS, PCOD? Is it more lifestyle, nutrition induced, or is there a genetic factor to it?
Sure. So yes, there would be a genetic component. So we always ask young women when they come in that did your mother or your sister or your aunts, anybody, other ladies have similar symptoms? A lot of times you'll hear yes. So there could be a DNA component, but living in a family, you don't just inherit DNA, you also inherit habits. And you eat the same way, you think about exercise the same way, you might manage stress in different ways. So there are habits that we also pick up or lifestyle factors. So I like to say this because similarly for type 2 diabetes, you might have had a tendency from your family, but if we focus on the lifestyle factors, there's a lot you can do to actually reverse this and turn it around.
All right. Now this is a big one. Probably a lot of people are going to take insights from this question. But how does PCOS, PCOD affect menstruation and how does this impact fertility?
So now I think one is menstruation is the key of basis of menstruation. How does it work primarily? Let us delve into it. So menstruation is a monthly cycle. That's why we call it a cycle. Typically, it's about 28 days cycle on an average. It may vary in women from 25 to 28, but the regularity is key. Now, how is it defined in nature is there is a process of growth of the egg in the human ovary in a woman or a girl, and then a particular time it actually ruptures and releases an egg. Now, after that, this process is called as ovulation. And after that, there is a typical fixed time in every woman. Once there is an ovulation, 2 weeks is the time. If there is a pregnancy happening, the period may not come. And if there is no pregnancy, period has to come within 2 weeks time of an ovulation. Now, in PCOS, what actually happens is multiple eggs are trying to sort of compete to ovulate. This is because of an uncontrolled LH surge. LH means it is a luteinizing hormone, which is actually secreted in peak by the stimulation of the control of the human hormonal control center, which is the hypothalamus and pituitary. These two organs sitting in the brain will control this cycle and control the ovary. This actually is designed to give the luteinizing hormone surge a particular level, and there is ovulation. Now, in PCOS, usually LH surges, but there is no ovulation. So what happens is body goes in an overdrive and it actually tries to give more LH surge. And this way, the eggs don't rupture, there is no ovulation, so the next period is altered. Means it is delayed because there is no ovulation. And body is trying to regulate it, but because of the metabolic limitations and alterations, disturbance, if we choose to call it, the cycle may postpone. Now, when this happens, there is less predictability, because if a woman is not menstruating for 2 months, either there is a doubt of pregnancy if she is sexually active, or there is no ovulation. So this typical thing will happen, and that's how it alters the cycle. Because there is no ovulation, there is less chance of pregnancy, but also a confusion with whether there is a pregnancy. We may call it as a pseudo-pregnancy. So an amenorrhea period or irregularity of cycles or prolongation of cycle duration. Also, even the amount of bleeding, we call it sometimes hypomenorrhea or oligomenorrhea, where the routine amount of bleeding, typically which is in a normal range for a woman for 2 to 4 days of bleeding, also may go down in these women.
That was complex scientific information, but also very, very necessary for people to know. Now, this is addressed to both of you. When does a woman or a girl, a young girl, when do the symptoms first start appearing, the age?
It can happen right from the time of puberty. If the child has had insulin resistance from a young age, we see obesity, we see insulin resistance, we see type 2 diabetes in young girls now. So with that syndrome, or even lean girls, if they have insulin resistance, you can see PCOS right from the very beginning. Even before the first period, they might start developing early acne. They might still start developing thick body hairs early than usual, because as Doc just described, this high LH is now driving extra male hormone effects. So even before the girl has had her first period, she may come in because the parents are noticing, or mom is noticing, thick black hairs in an early age before the periods have even come, because the male hormones have started off. So puberty, bone age gets affected. So in terms of how the girl is going to grow, you'll see that there is an alteration in how the height can happen. So really early impact can happen. It's important that you, being in the pediatric space, JIVI is trying to get younger families to know about this. They should think ahead and try and catch it early, because then you can make changes earlier.
So the signs are always there.
Yes, if you look, you need to look.
Right. What are some useful tests that are used to diagnose PCOS, PCOD? Or is it ultrasound is the first step?
So there are 3 aspects of this. One is the clinical signs, picking up the clinical signs and symptoms. Second is the radiological tests like ultrasound. And third is the hormonal tests, which is surprisingly in most of these girls, even in sometimes we call them classical PCOS, the reports may not be altered, but you need to actually evaluate the whole patient as a holistic approach, by a holistic approach to match the clinical signs and symptoms with the radiological appearance and then the hormonal assay. So when you talk about radiology, ultrasound is the commonest, easiest test to pick up the ovarian appearance. So it may be a PCOD, and then the metabolic assessment is done by the hormonal tests and especially measuring insulin resistance. So the test which we are is FSH, that is follicle stimulating hormone, luteinizing hormone, which typically are to be done on day 2 of the cycle, which sometimes may be difficult if the girl who's coming has no periods for 5 months for that matter. So the third test is the fasting insulin, because that will actually measure the insulin and its resistance in that particular patient. Another thing is the precursor of the hormones, estrogen and progesterone, and the androgen. So interestingly, we have to know, for the knowledge of common society, is that all these sex steroids, they are basically steroids and they are actually derived from cholesterol. And any disturbance in cholesterol metabolic activity or process will lead to imbalance in the production of different sex steroids. So there is this precursor of progesterone, testosterone, and estrogen, which is called as epiandrostenedione. So we measure DHEASO4, which is dihydroepiandrostenedione, which is an important marker to understand the levels of the hormonal derangement in these patients. And then the testosterone estimation, estradiol, and progesterone estimation in these patients. Besides this, also we have to sometimes evaluate their thyroid status, because these are interrelated complex mechanisms underway. Besides thyroid, there are certain other tests. We also have to analyze their body mass index with relevance to age and their genetic constitution. So this is overall a complete analysis. Prolactin is one important hormone, sometimes in high stress, that also can get reading. So this polycystic ovarian syndrome is an interplay, a vicious circle of cause and effect. Cause gives effect and the effect gives cause. This is a very complex mechanism. So depending upon each patient, without overdoing certain tests, we can actually holistically evaluate such girls.
Yeah, and that's eye-opening information there. We spoke a lot about insulin resistance. Could you please help us understand and simplify what is insulin resistance for the common audience?
Yeah, I'll just add one more point to the syndrome and diagnosing the syndrome. The reason that this term also syndrome exists, this umbrella vague word of syndrome, is because each girl or woman with PCOS can behave in a different way. Somebody may come with an acne predominant pattern, someone may come with hair thinning on the scalp, someone will come with loss of periods, loss of fertility. So, and someone may come with normal hormones, someone will come with DHEAS is high, someone will come with androstenedione high. So the whole idea is not to try and Google this out, but please visit your doctor and have the doctor sit with you and help you understand that, because lots of people now are going on the internet and wondering, am I going to not get pregnant ever again? Google is telling me I'm not going to have a baby. Go sit with a professional to work through this syndrome and to pick up what can you do. And, I just want to add that because working through this can be scary sometimes to make sense of all the reports, and so many things have to be tested. So work with a professional who gives you that confidence.
Yeah, I think that's solid information, because the easiest thing is now forget Google, but everybody is just relying on AI and give me what my symptoms are and tell me what the condition is. Yeah, so back to insulin resistance. How would you explain that to a common man?
Yes, so you'll wonder, we're talking about the ovaries. Why are we talking about insulin? Insulin has got to do with diabetes. What's the connection? Actually, there's a very strong connection, which is even in a lean girl, she can have insulin resistance as the hormonal driver of the problem in the ovary. So yes, when someone might be overweight or has pre-diabetes, we know they have insulin resistance, but insulin resistance is a bucket disorder, if you will, that as Doc mentioned, how LH is trying to help you. LH is not bad. LH is trying to solve a problem. Similarly, insulin is trying to solve a problem. Now, what is it trying to solve? Insulin is a master metabolic hormone. Yes, being a diabetes doctor, I'm talking about insulin all day long, but so is Dr. Uddhav, because insulin resistance is playing into every doctor's clinic nowadays. What is happening is insulin is trying to prevent this person from developing high blood glucose. With the lifestyle, of course, there's DNA, but today's talk, we're hoping to empower your audience with what can they do about this. With the lifestyles that we live, the food that we eat, the chronic stress that we have, the sedentary lifestyles that we take on, with bad sleep, okay, these are 4 major lifestyle areas that I look into: nutrition, sleep, stress management, and exercise. There is a tendency for the blood glucose to rise, but the body doesn't want diabetes. So what will it do? It will push more insulin to bring that glucose down. So the initial stages, you'll have normal glucose, and if you only do the glucose, you won't catch it. You need to look at the insulin levels to show, oh, we are having normal glucose because the body is overproducing insulin. So it's a combination of glucose and insulin you have to look at. As things progress, if the lifestyle does not change, insulin levels staying high, the body will no longer be able to manage that glucose, and you'll also start to see the glucose levels creeping up. There are other parameters that we can look at for looking at insulin resistance. Within the lipid panel, there are things you look for. But in short, insulin resistance is a common thread between not just PCOS, obesity, diabetes, blood pressure, all kinds of conditions that are linked to this. So it's a major problem we need to talk about.
This brings us to the next segment, that is hormonal regulation with nutrition. So my question to you is, does obesity cause PCOS, or is it the other way around?
Yeah, so you already helped me answer that with the previous question, which is insulin resistance, I would consider to be the common factor. So if you can address insulin resistance, you will be addressing obesity and PCOS. So when people come in to work with me on lifestyle change, I always help them see what is the bucket of things that they're facing, which all come down to the common pathway of insulin resistance. And we look at that to then tackle it from all the lifestyle aspects that can help reverse this insulin resistance. So before you get sick, you can actually turn it around.
And how does one manage their weight when they have PCOS? And I assume there'll be a lot of sugar cravings and things like that. And what is your advice for them?
So people don't like to hear that I'm going in now and they're going to take away my food. So when the family comes in, they might go stop at the chaatwala before coming. I've had this happen. Doc, I had the sev puri before visiting you because I know you're going to tell me to stop my favorite foods. So that is the psychology issue that comes in, is people think we're going to put them on a diet. We're going to tell them, don't eat this, don't eat this. Because you hear the word insulin, you think diabetes, you're like, I'm assuming you're going to tell me to stop my sweets, stop my junk food, my favorite tasty food. And this whole panic starts. So instead of doing that, because if you're going to do a tug of war, how is this going to sustain as a lifestyle? It'll be a diet. Maybe you're very scared, you'll do it. And sadly, we see, Doc, you probably see the same thing. Let me work on it right before these photographs have to be taken, before this wedding has to happen. Let me, short-term fix something. But we're here to talk about how do you help you give something that's actually going to last for the rest of your life. So before taking away somebody's sugar or carbohydrates, what I always focus on is assess how much protein they're getting. Are they getting enough protein from morning? If we fix that, because most people in India are protein deficient. They're starting with carbohydrate-based breakfast, lunch, and dinner. They're hungry all day long. Now, if I start taking that food away, they'll be more hungry because high insulin, high carbohydrate, high insulin, I'm hungry. So what we do is we up the protein first. This helps them feel less cravings across the board. Then I'm not doing this tug of war with them like a chore police, They feel less hungry, less cravings, and then automatically it's easier for them to decide when and how much they want to have their carbohydrates, sweets, things like that.
Right. So, Doc, are there any other conditions associated with PCOS?
Yeah, so long-term effect of PCOS can lead to multiple problems. So the longer you're exposed to insulin resistance, then you can end into diabetes. And diabetes, as you understand, it can involve all the organs depending upon the control with the individual practices. That is one of a major cause of the morbidity and the lifestyle challenges all over the world. Compounding with obesity, it is a bigger challenge, and obesity with itself brings in a lot of challenges. A lot of people may have joint issues and even issues with cardiac problems because of diabetes and obesity coming together. And not to forget the stress with that. Another thing is psychological aspect of these patients, because they enter into, because all the surrounding, they may actually have a feeling of getting body shamed. So they have behavioral alterations. They want to avoid things. They try to do things away from the limelight. They eat more away from the limelight, and all those behavioral patterns because of the complexes. And that actually pushes them more towards the disease. Another aspect in girls, if they are exposed prolonged to PCOD, they can have hypertension in the long run. And then what we call as, if they live longer beyond 40, 45, 50, if they have some other genetic predispositions or not, they are also exposed to having a higher risk of cancer related with the body of uterus. Because this environment starts giving a hyper-estrogenic environment over a long run, besides androgen, and then that can expose them to the risk of endometrial cancer. So by and large, prevention is the only key. Behavioral alteration plus visiting a specialist on a regular duration, support of the family and peers is very, very paramount, allowing these people not to slip into psychological deprivation and keep them motivated to be aware about their syndrome, where there may be genetic predisposition. Nobody can measure the extent of genetic predisposition. So it's a combination of modifying their lifestyle, assisting them to maintain a good metabolism, which keeps them on low glycemic index and allows their body to do the rest, to alter and keep them away from the effects of polycystic ovarian syndrome in the long run.
So we've spoken about all the issues related to PCOS, and that's sounds like a dark world. But now let's focus on the silver lining. What are the treatment options available? Let's start with conventional treatment options.
So first and foremost, and I'm sure Dr. Roshni also is emphasizing that understanding the patient, giving them a patient hearing, that itself is a major step in treating these patients. Because once they establish trust and confidence in the caregiver, then they can open up and actually discuss, because lifestyle and psychological aspect are to begin with. Because it is one thing to have fever and take a dolo at home twice and take care of the fever. But it's another thing to diagnose the cause of fever and treat it at the root. So here we are looking at treating this whole thing at root. So we can start with oral hypoglycemic drugs, which can maintain a low glycemic index in the individual. So that can actually take care of the insulin resistance. Assess their diet patterns, behavioral patterns, lifestyle, diurnal patterns to keep a check, because as we all know that the body secretes a certain hormone at a certain time, which is a diurnal clock rhythm which it maintains. If you disturb this, people who are genetically predisposed and disturb other lifestyle issues, then they are going to be exposed to PCOS. So that is one aspect. Second is we add oxidative stress which happens in these individuals to autocorrect. So at the cellular level, their metabolism is going haywire. They are adding factors, and that is pushing the body to try to correct it, but it is now under oxidative stress, besides the psychological stress of the human being. So we give antioxidant micronutrients like myoinositol, vitamin D, utilization of calcium ions at the cellular level. This can alter the cellular mechanism to actually enhance insulin receptivity and its sensitivity, and that can actually assist in modifying the disease progression. That can change the ovulation pattern, make it more regular. Then we go to the weight loss, dietary, exercise, altering their metabolism from a carbohydrate over surplus metabolism to the protein based shift, and analyzing their diet in such a manner that we optimize the utilization of micronutrients and contents of their diet, balancing it with good sleep, good stress management, and at the same time, exercise, which has to be balanced. So, for example, if we overdo the exercise, so I've seen patients who start, I am doing cardio, and then they get ligament injuries in 3 months because the instructors are pushing them more. And then they stop doing it, and then their diet requirement increases because as a result of heavy metabolic exercise and nutritional supplements offered by the instructors in the common gyms, they enter into high craving and higher diet requirements and stop the exercise because of the injuries or lack of motivation, because sometimes they are pushed harder in the. So it's very important to optimize these things and not overdo, and visit the actual specialist, like multi-holistic approach, multidisciplinary approach, where 3 or 4 consultants who are actually specializing to treat them together.
Right. Would you like to add anything?
There's a couple of points. I have a question. Do you use berberine? Have you seen it help?
Yes, so we use in some situations, but we have not been able to analyze in the long run.
The myoinositol,
Yes,
definitely.
so yes.
Yeah, sure. I'd like to add a few points. Everything agree with what Dr. Uddhav said. And it's very sad that when you just, like, it's so easy to body shame a person just by looking at them. We assume we know everything if we see that they're overweight. And sadly, we'll tell these young people, you need to go to the gym and burn this weight off. The calories in, calories out model has failed. So the idea, if a girl or a young woman is being told you need to spend 3 hours on the treadmill for that samosa you ate, it's wrong. And it's not fair. And they're trying so hard to lose weight. I have so many women who come to me saying, I tried losing weight in the gym and it never worked. You cannot lose weight on the treadmill. You're going to only manage the fat loss in the kitchen. And if you do things right in the gym, you'll be looking to gain muscle. Now, I need to speak about this. I actually went ahead and became a personal trainer. I got certified as a personal trainer in 2016 because doctors don't know about exercise. We know what to do if you get a fracture, okay? But we don't know how to actually help you build muscle, build a workout routine that is injury-free. So we have patients who will say, I can't exercise because this, like Doc said. And then the doctor has to keep quiet because they don't know how to come in and solve that with the patient. So knowing about hormones and muscle, we need to say a few things. People have this fear or phobia that if I go to the gym as a female, I'm going to bulk up. I don't want to be bulky. This is a misunderstanding. Strength training is very, very crucial. Building muscle improves your hormone profile. It improves how your insulin works. It helps you prevent diabetes. For any woman who's interested in a long, healthy life, she's going to be interested in not having osteoporosis when she's older. We need to know that building muscle is part of that. So the exercise routine has to be, yes, some cardio for getting in your steps and being active, but for sure they have to focus on muscle building. And no, protein supplements do not make you gain weight. It is the additives that might be there, emulsifiers, flavors, but replacing protein in somebody who is deficient in protein, if you're a vegetarian, for example, and you don't have enough in your diet, you need that supplementation, not just because you went to the gym. Some people will say, I take protein supplement on my gym days. Protein requirement is every day. 1.2 grams of protein is required every day per kilo body weight, whether you went to the gym or not. Okay. So that is something we have to help understand the myths and misunderstandings. Oh, should I give protein to my child? Why are you giving branded power drinks, energy boosting, brain boosting drinks to your child because some companies market it to you? Why are you scared of giving protein to your child when they need protein to be a growing body, right? So give an unflavored, unsweetened option, but give them the raw material. If you can figure out protein in your kitchen naturally, always the top preference. No need to take powders if you're reaching the count of 1.2. So we need people to count their protein.
Right. So the treatment option seems to be a combination of both clinical and holistic approach. Let's talk a little bit about birth control pills, metformin, supplements that are used nowadays to tackle PCOS.
So now the thing is, as I mentioned, and I gave the analogy of, say, Dolo or a paracetamol for fever. Most of the times, mothers come with the girls and irregularity of periods. And commonly what happens is, to regularize periods, oral contraceptive pills are prescribed by the consultants, whoever they go. So what happens typically is it masks the disease. So the family or the mother ends up giving those 3 months pills to the girl. She starts getting regular cycles because it's actually regulated by the pills. And she feels that she's fine. But actually, it's the masking of the disease. So I want to clarify this for all the people, that they should never try to regularize the cycles by drugs. They should actually only temporarily check whether there is no other reason or anomaly causing this problem of irregular or prolonged cycles. If you confirm an ovulation, start working with all these measures: diet, lifestyle, psychological, and other aspects, and then correct the metabolism. Also, quite a few times now, per se, what I'm seeing in the last 6-7 years is, in the ultrasound, the girls who are overweight and are having clinical signs of polycystic ovarian syndrome also have a coincidental fatty liver.
Yes.
This is actually a very common discovery nowadays, and it is suggesting that liver is also under duress, and this can expose them. So what is happening is their metabolism is slowing, liver is not working. The liver has to be challenged, it has to be working. And that's the reason that muscle, which is supposed to actually uptake of glycogen, where it has to have insulin sensitivity and digest or use the blood glucose, keep it in normal levels, is actually being stored as free fatty acids and cholesterol and adipose tissue conversion. So the body is shifting its cycle from utilization of sugar to deposition as a fat. And this is the cycle which we need to break. So that is one aspect. Once we correct the anovulation, usually the quality of egg formation regularity becomes better, and the chances of pregnancy happening is increased. And at the same time, one more thing happens typically in the patients who are having PCOS. Even if they conceive accidentally, sometimes the quality of oocyte is not good, and they have higher risk of missed abortion or a missed pregnancy. That means the egg is not mature enough and the pregnancy happens, but it doesn't continue because of inability of having adequate genetic material to actually form a life. So when you correct the metabolism at heart, at the root, the chances of having better quality egg production, regular egg production happens, and these women can conceive normally as well, or with little medical assistance. Also, one more aspect I want to highlight: when they need aggressive, because now is the age of cafeteria approach in fertility. Now couples or women come with a particular timeline that, doctor, now we want to get pregnant in this 1 year, because then I'm shifting to the US, then I'm going to be working for a corporate multinational giant, and then I'm not going to be having time. So we want to plan only this. In this age, we are having assisted reproduction techniques. So patients with PCOS are at a higher risk of multiple ovulation and multiple pregnancy, and also a little risk of, we call it as hyperstimulation, because there are multiple eggs. So we need to correct that before subjecting them to assisted reproduction, so that they have better quality eggs and also a better chance of pregnancy, which has a successful delivery outcome, what we call as take home baby rate.
So, have you seen PCOS being reversed in some of your patients?
Absolutely. The heart of PCOS control and treatment is in the discipline and maintenance, as is in obesity, as is in lifestyle. If one regulates, it is my stronger belief also as a human being, when I feel that health lies in the mind and the gut. Everything lies in the mind and the gut. If your mind is disciplined, your gut will listen, and you don't feed stuff to yourself, regulate your activity, combat your stress, I think most of these kind of disorders will stay away from you, and you can maintain yourself in that zone.
All right.
Can I add to that?
Yeah, it's not.
I will agree completely that the OC pill and the metformin, the spironolactone, These are kind of blocking symptoms. They may give you the relief of symptoms, but they're not treating the PCOS itself. Maybe 10 years ago in my practice, I used to prescribe these as the first thing. You've come with symptoms, I'm the doctor, I have to give you the medicine. Now I've taken a lifestyle first approach, and I haven't prescribed OC pills or spironolactone to someone with PCOS in a very long time. And we see the PCOS reverse, we see the fertility come back. A bit of nuance here when girls are told, I've had girls in my children's classroom be told when they're 14, 15 years old, you will not become a mother. I've had 25-year-olds told, you better get married, you better have the pregnancy now because you won't be able to conceive later. These are really horrible things to say to women. Fertility or pregnancy is a gift. It's a privilege. It's a right, but it's also a choice. We should not talk to women like this as though they're baby-making machines. And we should not destroy people's confidence and self-worth. And what Doc said is absolutely right. Healing or self-care or self-love to do this for the long term comes from, if you have to stick with something for the long term, it comes from loving yourself and wanting to do this because you're worth it. How will we get long-term motivation if we destroy somebody's self-esteem in that one clinic visit by saying such horrible things to people? So we need to give them that respect. Show them that I know you're here to get better. I know you don't want to harm your body. Maybe you didn't know what's to be done. Let's show you how to reverse insulin resistance. And I'm sure that you know how you're going to feel better if you make these changes. And then that trusting relationship that Doc mentioned, that's how you actually help these people succeed long term. But yes, I've seen lots of pregnancies happen without ever this you will not be fertile thing catch up on any woman with PCOS.
Is there a proportion of women with PCOS who require surgery, corrective surgery?
So surgery was a stopgap arrangement 20 years ago. And as a laparoscopic surgeon, most of the times we would see patients who were in a hurry to conceive. And especially these patients who had PCOS, the basis of this hyperactivity in the ovary actually creates a hypertrophy of certain cells called as theca cells, which actually try to produce more androgen or testosterone, and that disturbs the ovulation, which we call it hyperandrogenism, and symptoms like hair growth and hirsutism stuff, and then poor ovulation. So at that time, when they were requiring, and when it is very difficult for them to go down on their body mass index if they are obese, or altering their metabolism with diet and exercise, then polycystic ovarian drilling was practiced. Now we have almost abandoned this procedure unless and until, as I mentioned, there is a particular couple or a lady who comes with a specific requirement that within this 6 months, doc, I'm not going to be able to change my lifestyle too much. I'm okay with I've understood this procedure and its ill effects, so to speak, what it may cause. Because one side effect of the PCO drilling, if it is not a balanced or optimized, it may lead to ovarian reserves reduction. And even in sometimes, if over-enthusiastically performed, can have ovarian failure, which is premature. So we need to really judge and utilize this approach. But in today's time, with awareness and healthcare providers like Dr. Roshni and like these interactions, bringing down the information in open and making the facts clear in front of people, they can make this can help them understand that modifying their lifestyle, they have the power to change their metabolism to a healthy metabolism and keep away the polycystic ovarian syndrome. And I have many examples. I had a girl who came, whose sister I had delivered. So mother got her that she's going to the US, but she's not menstruating for 6 months and started developing hirsutism. And she was traveling to the US. So her mother was worried. She's not going to be cooking. How do I manage her diet and stuff like that? So I learned at that time that sitting with that family and understanding their normal diet since childhood for that girl, and then taking her through that. And when she's going to get married and going to be planning her first child, I said, this is in your hands. You're going to the US. It's you who has the power to control everything for yourself. That girl prevented her body mass index from going haywire. She practiced a very diligent lifestyle in the US. And after that, she reversed her hirsutism. She got her body mass index in the normal range for her height and age. She practiced healthy lifestyle, good sleep. After 7 years, she got married and she conceived when she wanted naturally. And this actually made me change the approach, as Dr. Roshni also had the experience to prescribe drugs which are mentioned, scientifically proven. But finally, we realized that if we motivate them, give them some more time, 6 months to 1 year is good enough, take their whole family into confidence, and also give them role playing. Sometimes it's just telling the patient or the girl, you should exercise. Then I tell the parents, why don't you exercise with her for 15 minutes?
Yeah.
The problem starts getting solved there because the blame is shared.
Yeah.
And then it acts as reverse motivation, because then they are together in this whole thing. And actually, for every person who has these kind of challenges, requires family by their side rather than pinning them down and decreasing their motivational levels or making them felt left aside. So this is a very important aspect, and I think this remains the mainstay, and everything becomes ancillary in my approach. So I've realized that when we do as holistically, we apply specialists who do lifestyle, diet modification, who understand exercise better, we understand the medical aspect and keep a check, motivational consultants who can motivate, and then utilizing the family fabric, peer fabric, not Googling too much. All these behavioral aspects, if we emphasize more and they get the confidence, and as she mentioned, do you not feel better when you lost 4 kgs? So it's not about losing 4 kgs. You felt better, and then your cycle came normally after 3 months. You realize that that can be used as a stepping stone. And we have to emphasize that you cannot springboard to normalcy in one shot. You are going to go back into the sink again in the polycystic ovarian syndrome if you just use as a temporary motivation, lose the way. Maintaining this whole thing is the key. And once you enter that, then I think it's a winning battle.
Yeah. So this brings us to the last segment, that is breaking the silence on PCOS and PCOD. What tips do you have for Indian parents and teens to tackle early symptoms and also the psychological and emotional aspects of PCOS?
So I think as we have covered it in a holistic way, the mainstay would be a very, very comprehensive approach which analyzes the familial factors, interrelational factors in the family, genetic predispositions from the medical aspect, lifestyle patterns of the individual, and then long-term goals of the patient. If we analyze this well, take the family along, the peer circles along, and utilize a holistic, comprehensive, multidisciplinary approach with the specialists who are actually addressing polycystic ovarian syndrome as a metabolic condition, then I think the patients and their families can find it easier to address this, prevent this if it has not happened, and if it has happened, deviate from the progression of the disease to the correction course.
Right. And you, ma'am?
Yes, agree with everything doctor has said. Today you've got an endocrinologist and a gynecologist, right? But the body is one. So PCOS is a gynecological and a hormonal, basically a metabolic problem. Families don't have to panic. Please, I think the first thing people need to know is stay in touch with your pediatrician from the early days. Get your young daughter to be visiting a gynecologist for preventive health checkups. Catch these things early, but please don't panic. Don't get into the blame game, right? This happens in homes a lot. Drama, a lot of negativity goes on as though it's a personal failure. It's not a personal failure. Start logging what you eat, not because someone has to take it away from you, but do you even know what you're putting in your body from morning to night? We want results, but that is the outcome. What is the input that is giving that outcome? If you want a different outcome, change the input. And the outcome is not to stand on the weighing scale every day, as Doc mentioned. It's about changing the inputs and tracking what you're doing, whether it's your nutrition or your sleep habits or your stress management techniques, not getting into this sense of personal crisis. And of course, the exercise. But start a process with somebody who can guide you in a structured way There's really no need to find this to be a life sentence or a death sentence. PCOS can totally be reversed and managed. It is not a lifelong condition that you have to deal with. Let's help people get to the root of it.
So thank you both for taking the time out. I know I have learned a lot from this session. I hope our viewers have too. Stay tuned for more science-backed, evidence-based discussion on JIVI Explains.